I would now call Dr. Pranathi Reddy to give her talk on doctors to lose license if Cesarean section rate exceeds 25%. Is this right? And following which I would request Dr. Rajesh Tiwari to give his address.
Respected dignitaries on the dais, ladies and gentlemen. So today I am here to talk about a burning problem in the field of obstetrics, rising cesarean section rates, and what is the action required. Who should pay and what are the consequences of this problem? Are there any remedial measures? There is no doubt that this is a global concern. We all know that C-section rates are rising world over. Our own country, the National Family Health Survey number 4 released in 2015 and 16, you can see that there has been a dramatic rise in C-section rates over the last decade. What is worrying for our state is that we stand at the highest rate of C-sections. If you look at the cesarean section rates and compare them to the national cesarean section rates, we are almost double there, both in private and public sectors. And all of us will agree that we need to act. And the government, in its entire sincerity, because it's the protector of public health, has started looking at this in a very serious manner. They have put both private and public sector hospitals under the lens for C-section deliveries, and warnings have been issued. Now, before we go into what is the correct remedial measure, who should lose licenses, I think it's important for us to understand what is the evolution of this problem. You know, why did C-section come about? Why should we be worried that the rates are rising? Why are the rates rising? Who are the stakeholders who are contributing to this rise in C-section? How should we address all these stakeholders' issues? And what are the effective interventions we can bring about to reduce C-section rates? Why did C-section evolve at all? If vaginal birth was so perfect, why did we find the need to resort to a C-section? And I think as medical professionals and as non-medical professionals, there are a number of conditions, medical indications, where if we didn't perform a C-section, it can lead to the death of the mother or fetus or a high degree of morbidity. There is no two thoughts that there are clear-cut indications where C-section is a life-saving procedure. And this has been endorsed by the World Health Organization, and World Health Organization clearly recommends that essential surgery should be a potential priority investment for the world's poor. And C-section is one of the surgeries which is listed in this group of essential surgeries. It goes on to say that access to specialist obstetric care, particularly C-sections, is seen as vital to the success of any safe motherhood program. So, if this is such a good surgery, why should we be worried that the rates are rising? Look, I mean, it's an evolution, isn't it? We've seen so many evolutions in the field of gynecology. We've seen mesh surgeries for prolapse. We've seen endoscopic and robotic surgeries. We've welcomed them. We've lauded these innovations. We've taught them enthusiastically. So why are we worried? Look at plastic surgery. A woman can just go up to a doctor and say she wants liposuction and die of pulmonary embolism, but it's given to her, isn't it? We've accepted patient choice. So in case of a C-section, what is the worry? Why are we worried that the rates are rising? This is because we have a safe alternative. And there is again enough scientific literature to tell us that the short-term complications for the mother, the long-term complications for the mother are definitely higher with a cesarean section as against a vaginal delivery. So are the neonatal complications. So the benefits of a vaginal birth are manifold. And again, WHO says that cesarean sections should be undertaken when medically necessary. So you don't want a woman who doesn't need a C-section to be subject to the risks associated with a C-section. That's why this worry is there. And why are we seeing this rise in cesarean section rates? Before we go any further on this, I think it's very, very important for policymakers, for doctors, to understand that rising cesarean section rates are contributed by both necessary and unnecessary sections. And this is something that we need to remember. An unnecessary section is defined as a section which you have undertaken with an idea other than preventing maternal and infant morbidity. But abnormal cesarean section rates, which has been the focus of media and government scrutiny, comes from the overall cesarean section rate, which reflects both necessary and unnecessary cesarean sections. There has been a tremendous increase in the necessary cesarean section rate also, and this has come about because we've seen so many advances in the field of obstetrics. We have ultrasound which diagnoses placenta previa, we have intrapartum monitoring techniques. Dr. Savita pointed out that we have so many advances in our allied specialties. We have fetal medicine where they're practicing fetal therapy through a hysterotomy, which essentially warrants that we do a C-section. We have infertility, which gives us patients who have, quadruplets, triplets. And we have neonatology, which is saving babies at much younger ages. The nature of these problems increases the rate of C-section in these conditions. We have women who few years ago would have actually died of their medical disorder, but because of advances in medicine, they are actually living, attaining reproductive potential. Their own physicians want delivery in more controlled environments. We as a generation have also inherited women who have already had cesarean sections over the last 20 years. You have a woman who has a previous 2 cesarean sections, the indication is non-negotiable. So at this point, it's very, very important for us to differentiate between the necessary sections and unnecessary sections. It's important that we focus on reducing unnecessary sections, and the WHO again has come to our rescue, and it has suggested that we have a universal classification system. It has very elegantly divided women and not indications into groups. So you have women who have certain problems, and they have provided 10 groups over here. All of us are familiar with it. And the groups 6 to 10 come under the necessary group. These are non-negotiable. You have transverse lie, you have breech, you have a woman with previous 2 cesarean sections, you have to perform a medical section in this. You have one group where you have to, weigh the risk-benefit analysis of a single previous section. There are 4 important groups where you need to separate the necessary from the unnecessary. And these are the groups where we need to focus on. Once we have established this, we now need to look at the stakeholders who are contributing to this rising cesarean section rates. We have doctors, obviously they come at the top of the list. We have patients, we have hospital administration, which in the public health sector is the government, and in the private health sector is the hospital managers. All of these people are contributing to rising rates of unnecessary cesarean sections. Let's look at the doctor as the primary stakeholder. How are they contributing to this? Look at these 2 cases. You have uncomplicated primigravidas. One of them has been advised a cesarean section, and one of them has been advised an induction of labor. Sounds familiar, doesn't it? And this has happened despite enough evidence to say that this is wrong practice. You then have the second case which goes on and has an induction of labor and is labeled failed induction and has a C-section. Again, we have enough evidence from NICE, from the World Health Organization, to say that this is not acceptable practice. It is completely non-evidence based. So why do obstetricians still decide on doing a C-section? If you look at the press, the press is only going to highlight on the fact that there's a profiteering motive. That, doctors advise C-sections because they want to make money of unsuspecting women. And I'm not going to deny that. Every profession, I think, has its bad eggs. Doctors, engineers, civil servants, politicians, uniformly, we will have people who are not up to the mark in that profession, who are not serving the profession to the best of their capacity. We cannot deny that. But if we are going to go down that route, we will be like ostriches burying our heads in the sand, because there are many other reasons for which a doctor may prescribe a C-section under these circumstances. It can simply be lack of knowledge. This may come from an obstetrician who's not sure of their clinical judgment, who's not sure of the infrastructure in which they are working, who's not confident of the backup they have, and they're advising C-section, and this is borne out by a number of statements, and you will find that very often they do have patient safety at their heart. So we should remember profiteering is a motive, but there are other reasons why unevidence-based practice happens. You also should remember that labor is a long process, it's not a procedure. It's impossible for doctors to achieve high levels of vaginal birth without teamwork, and I think that's very right, sir, what you said. We should be looking for teams to supplement us and help us in achieving these vaginal births. So how can a doctor get better First of all, they need to improve knowledge. They have to regularly update themselves. They have to commit themselves to evidence-based practice which can stand the test of second opinion anywhere in the world. They should strive towards establishing teams, and they should introduce audit into their practice, and I will be talking about this subsequently. Now let's examine the patient. How have women started contributing to this rise in unnecessary sections? Look at this, we get this request very often. Elderly woman, IVF pregnancy, wants to have a delivery muhurtam section at a particular period of time. Cesarean delivery on maternal request. There's an acronym for it. Whenever any medical condition gets an acronym, it's here to stay. CDMR is here to stay, and we have to accept it and see how we are going to deal with it. Fear of pain. This is a true case. This is somebody, a Yale student has come and done research, and he's interviewed people. Here is a woman who's telling us that my mother told me that her delivery was very painful and I shouldn't go through it, and she would have opted for a section if it was well established at that point of time. So, previous traumatic birth, fear of loss of control, these are reasons why women are requesting a section. So what should we be doing with these women? The question of autonomy, you know, she's asking you for a surgery. A plastic surgeon, liposuction, abdominoplasty, you're not thinking twice about it. They are having it, isn't it? So if she wants a cesarean section because she's fixated on it, should we be denying her her autonomy? I think the better way of handling this is we need to make women partners in the decision-making process. I think it's important to spend time with them, give them evidence-based information, and formalize it into a valid consent following all the 9 cardinal principles of consent. This should be recorded. In this case, you have to talk about a zero intended benefit when it's coming for no medical reason, along with the risks associated with this surgery. Consent should always be given under elective circumstances because these requests come under elective circumstances. You need to do your consent in the outpatients, allow the woman to reflect on this decision, and I'm sure these will come down if we spend this time with them. And you heard the previous lecture, there is a low level of tolerance to adverse outcomes at this point of time, both maternal and neonatal. We all have heard of this outbreak of attacks on doctors. This is a socio-cultural issue. You know, nobody wants adverse outcomes. It's a combination of a smaller family and ascendance of the woman's position in society. Few years ago, the best way, 15 years ago, if you saw movies, how did a woman die? Childbirth. And it was accepted. People thought it's fine, you know, a woman does die in childbirth. That doesn't happen anymore now, and it's a good thing. And there is an intolerance on the part of patients about uncertainty that rests with vaginal birth. You know, what is going to be the outcome? Will I end up having a section? Will the baby be all right? I'll be in labor for 12 hours. There's a lot of intolerance and unacceptance of this uncertainty. And Hema Divakar in her interview quite correctly put it down. She said that very often when things go wrong, patients ask us, doctor, why did you not do a C-section? They are never going to ask us, why did you not try for a normal delivery? Often when things go wrong, this is, so are obstetricians then leaning towards cesarean section because of medical legal issues? May be true, but I think that's not a solution. Again, you should make the woman a partner in the decision-making process. Nobody should go away with the thought that a vaginal birth comes with no complications. It's important for the public to understand that becoming pregnant is assuming a risk. It is not risk-free. Approximately 10% of women who plan and achieve a vaginal birth will experience some type of complication. And once you get pregnant, not treating is not an option. Once a woman gets pregnant, she has to deliver either vaginally or by a C-section. So this is a condition where non-treating is not an option. So the patient, they need to be educated. The counseling should start very early on in pregnancy, as soon as they get pregnant. Childbirth preparation classes are not about lamas and breathing. They are about imparting evidence-based information about the process of pregnancy, labor, delivery. And they should become partners in decision-making process, and they should leave behind this all rights and no responsibility attitude. Now let's come to the third stakeholder. This is the hospital administrations, and they are responsible for infrastructure and staff, and this is so important to achieve vaginal births. You know, just the will of the doctor and patient is not enough. Labor, delivery are long processes. It's not a procedure, it's a process. We should remember that. It can have unexpected outcomes at unearthly hours. You may have a woman who bleeds at 3 a.m. in the morning and you need liters and liters of blood to treat her. You may have a woman who needs a C-section at 2 a.m. and no availability of an anesthetist. You may have requirement for neonatal resuscitation, which happens at odd hours. And we need to do this in teams because of this long process. If a patient is in labor for 12 to 24 hours, you need to be backed up by effective personnel. Whether you're going to call them midwives, whether you're going to call them specialist obstetric nurses, each healthcare system should determine which team works best for them and should develop that team. And then only we can make safe vaginal deliveries possible. So you need to have a huge infrastructure to make safe vaginal delivery possible. Organizations and administrations and governments should focus on developing protocols and operating pathways, in providing an ability to perform emergency cesarean sections, providing blood bank facilities or access to blood when any patient is in labor, and making sure that the patient is well supported. And developing an obstetric nursing certification programs where you have, just like after MBBS we are doing specializations, I think nurses should be able to do obstetric nursing and aid the process of labor and delivery. It is too expensive to just have doctors looking after it. Infrastructure and staffing needed to achieve large numbers of successful vaginal deliveries is far more expensive and resource intensive. If you sectioned every woman, it will work out to be cheaper. But if you work towards having a safe vaginal delivery, you have to invest a lot in infrastructure and resources. And that's why there is a perception both among doctors and patients that if you have a planned cesarean section in daylight hours with all senior doctors available, with the operation theatre open, it may be safer than a vaginal birth. This is perceived as safer because of the fear of the uncertainty. So managers as stakeholders have to emphasize on infrastructure. They have to have minimum mandatory standards for processes of labor and delivery and place of delivery. They have to insist on reaccreditation and education of the staff, build teams, and have stringent credentialing. So once we've looked at all these stakeholders, here comes the million-dollar question. What is the ideal cesarean section rate? There are no members of the press here, I think. Leer kadandi. Eppudu chusna. WHO's 10 to 15% limit, led by wealthy urban women, exceeds WHO limit. C-section rate is what what does WHO recommend? You just go to Google and Google it. It doesn't require much intelligence. WHO has clearly stated and